Okay, so the topic for the today's class is actually imaging in pediatric chest masses. So we'll be covering the chest masses in two parts. Today we'll be covering the congenital lung masses, as well as we'll be covering some of the common mediastinal masses. In the next class, we'll be covering the most significantly, we'll be covering the chest wall masses. And if anything is left from the today's talk, we'll cover it in the next session so that today's class is not very long. So coming to the classification. So we have already covered the congenital part, congenital masses, such as the CLO, CPAM sequestration in our previous classes of congenital lung malformations, right? Along with it, we can have the inflammatory masses, which can include lung abscess or hydatid cyst. And among the neoplastic masses, we can have metastatic lesions, or among the benign lesions, we can have recurrent respiratory papillomas. We can have fibroliomas, fibroliomatous hematomas, and hemangiomas. Among the malignant lesions, we can have inflammatory myofibroblastic tumor. We can have pleuropulmonary blastoma. We can have aggressive carcinomas like mucoepidermoid carcinoma, carcinoids, anaplastic lymphomas, or rhabdomyosarcomas, right? So among the mesenchymal lesions, we can again have the leiomyosarcomas, rhabdomyosarcomas, or the fibrosarcomas. Carcinoids, hemangioparasitomas, Hodgkin tumors, these are basically the chest wall lesions that we'll be covering in the next lecture. So coming to the pleuropulmonary blastoma. So what do we know about the pleuropulmonary blastoma? It is the most common primary lung malignancy that is seen in the children, right? The most common age group that we see is less than 6 years of age, and it has been seen that almost we'll be reading about the types of pleuropulmonary blastoma. So basically, we have actually three types. We have three types of pleuropulmonary blastoma. So this includes the type 1 is actually the cystic one. Then type 2 is actually the mixed component in which you have solid and cystic areas. And type 3 is a purely solid region. So it has been seen that although the age is less than 6 years, but the cystic variety, it is mostly seen in around 10 months of age. And the mean age of mixed pleuropulmonary blastoma is 34 months. And the type 3 is approximately around the 44 months. So you can see that almost the incidence of the solid type of pleuropulmonary blastoma is at a later age, whereas the cystic type of pleuropulmonary blastoma tends to occur at a younger age. And that is why the cystic pleuropulmonary blastoma has to be differentiated. And actually, its most common differential is always the CPAM that we had discussed in the previous lectures, that it is also a cystic lesion. And it is a congenital lesion, and it needs to be differentiated from the pleuropulmonary blastoma. And we'll discuss as we go along. So basically, as the name suggests, what are the cell types that are within the pleuropulmonary blastoma? We have the blastomatous kind, blastomatous cells, and we have the sarcomatous component. So these are the two types of cells that we have in the pleuropulmonary blastoma. Whereas in the adults, you mostly have epithelial or mesenchymal type of tissue. Important thing about the pleuropulmonary blastoma is that it can actually occur in a pre-existing lesion, right? Pre-existing lesion, and pre-existing lesions like what? Like CPAM, like sequestration, like bronchogenic cyst. So the congenital lesions that we are discussing, pleuropulmonary blastoma, can develop within these lesions, and that is why we have to be careful about them. And another important factor about pleuropulmonary blastoma is its association with the DICER1 mutation, particularly if you can remember 14q32.13. This is the genetic marker for the DICER1. And some other malignancies are also associated with DICER1, which you may or may not remember, but these are basically nephromas, pinealoblastomas, and thyroid cancers, or ovarian sex cord tumors, or embryonal rhabdomyosarcomas. But the important thing is that you should remember it with the pleuropulmonary blastoma. And sometimes you can actually advise the patient with the getting the genetic mutation testing done for the patient. Right. Now coming to the imaging, what are the important imaging factors that we want to know? So basically, they are more common in the right hemithorax. Right. I'll show you the images also, obviously, but these are some salient features that you should remember. So it can have it can have actually any type of appearance. It can be either cystic, or it can show necrosis, or it can show hemorrhage, and sometimes it might show calcification. So you remember that it has a heterogeneous appearance. The pleuropulmonary blastoma has a heterogeneous appearance. Right. Another common finding that are imaging wise that is important is that pleural effusion, as well as pneumothorax. Right. Pleural effusion and pneumothorax are frequently associated findings with the pleuropulmonary blastoma. Metastasis, if it occurs, commonly occurs to the liver or to the brain in the CNS, right? And obviously, because it occurs at a younger age and has a poor, so this basically this tumor has a poor prognosis, right? Although pleural effusions are common in a pleuropulmonary blastoma, but the important thing again that you should remember is that chest wall invasion is not very common in pleuropulmonary blastoma. So this actually helps you to differentiate it from the other malignant lesions of the chest wall that we'll be reading in the subsequent lecture. So this is one thing that you should remember, that it will be basically a large heterogeneous solid cystic mixed or solid mass which is occupying the hemithorax and will have a varied appearance, can have metastasis and has normally a poor prognosis. And chest wall invasion is not very common with the pleuropulmonary blastomas. Again, as I told you, the common differentials are CPAM, because especially of the type 1 types. Then again, for the type 1 type, we again have a differential of pneumatocoel, because it is also a cystic lesion. Sometimes pulmonary interstitial emphysema can also confuse you if it is localized. Then how do you actually differentiate between the CPAM and the pleuropulmonary blastoma? So there are actually only a few points that can actually tell you. So basically, CPAM is a congenital lesion, right? So if the patient has had a fetal ultrasound and antenatal scan, so these are mostly detected in the fetal time. Whereas the pleuropulmonary blastoma, it mostly occurs postnatally. So the prenatal postnatally. So the prenatal ultrasound will not show this mass lesion. So this is one differentiating feature. And secondly, the type 1 of the pleuropulmonary blastoma that we tend to confuse with the CPAM can actually be multifocal, unlike the CPAM, which can have multiple cysts but is rarely multifocal in origin. Right. So if you have multifocal cysts in the lungs, then also you should consider a possibility of pleuropulmonary blastoma. So I was telling about the type 1 and how do we differentiate it from CPAM. So the other differential that we want to, other type that we want to differentiate is basically the type 3 CPAM, which is purely solid. So we want to differentiate it from the other solid masses of the chest wall. So again, as I told you, chest wall invasion is not very common in pleuropulmonary blastoma. And that is how you can suspect a pleuropulmonary blastoma in these cases. Right. So coming to the images. So what do we see on the chest X-ray? It is basically a large, it is basically an opaque hemithorax, which is occupying the entire right chest. And we can see that there is mass effect in the form of contralateral shift of the mediastinum. We cannot see the diaphragmatic shadow also. And when the CT was done for this patient, we can see that this is basically a mixed type of pleuropulmonary blastoma, in which we have some solid areas and we have some cystic areas, some non-enhancing areas. And this is basically, and we have some associated pleural effusion also, right? But we do not see any chest wall invasion, and the lesion is limited by the diaphragm and is actually compressing the mediastinum, right? So these are the other additional images which are demonstrating the same thing, how it is going posterior to the heart and in the infracarinal location. And this is again, we can see that there is no neural foramina extension of the lesion and no chest wall invasion is there. So this was a case of pleuropulmonary blastoma. Another case in which we see that there is a large mass lesion which is actually occupying the left upper zone as well as the left middle zone and almost the left lower zone. There is no associated pleural effusion, and we can see that there is some mass effect because the cardiac shadow has actually has shifted towards the right side. This is the lateral chest X-ray in which we can see the mass which is occupying again the some part of the middle mediastinum and some part of the posterior mediastinum. And when the CT was done for the patient, we can see that again we have a mixed density mass lesion which is seen within the lung, and there is no chest wall invasion and no neural foramina extension is seen, and the surrounding lung parenchyma is absolutely normal. So this was again a case of pleuropulmonary blastoma. Coming to the cystic type of pleuropulmonary blastoma, as you can remember that when we had read the CPAM, this is a very similar picture as we had discussed. And sometimes you are actually, if the patient does not have an antenatal ultrasound or, so sometimes we are just not able to, and the lesion is not multifocal. Sometimes we are not able to differentiate the pleuropulmonary blastoma from the CPAM. But the CPAM is again actually prone to recurrent infections, and this cystic lesion will be continuously increasing in size because it is not a cyst, it is actually a tumor. So, and it can also metastasize, right? So sometimes if we have a single image, we sometimes might not be able to differentiate between type 1 CPAM, the CPAM and the type 1 type of pleuropulmonary blastoma. So if you have a patient which is less than 10 months, right? If you have an infant, so always you can keep a differential of a cystic type of pleuropulmonary blastoma in your differentials. And the only differentiating points, if you have metastasis, then you are more sure that you're dealing with a pleuropulmonary blastoma. So as we can see that there is a lucency within the right upper zone and mid zone, and the surrounding lung parenchyma is absolutely normal. And when the CT was done, again, we can see that a large cyst was seen with an adjacent smaller cyst. And this was a case of type 1 of the pleuropulmonary blastoma. Now coming to the second tumor that we are discussing, that is the infantile fibrosarcoma. So as the name suggests, so it is basically a malignant spindle cell basically the primary cell which is malignant is the spindle cells which are it is a spindle cell involvement is there, and it is commonly seen. The age group is basically less than 1 year of age, and more than 80% of the cases are seen in this particular age group. The clinical features of patient are mostly of the respiratory complaint, and sometimes they can have fever, or they can have anemia or hypoglycemia. These are the common presenting features of these large masses. Again, it is very difficult to differentiate among the various masses just based on the imaging. So again, we have a genetic, nowadays genetic mutation, genetic testing is done in most of the cases where it is feasible, because we can actually reach up to the genetic makeup and we can better treat the patient. So the translocation associated with this is the translocation 1215, P13, Q25, right? And again, this is the genetic mutations are not very important to remember, but if you are reading in a greater detail, then obviously it helps you, right? Another important thing is hemorrhage. So hemorrhage is very common in this tumor. And again, you know that hemorrhage appears hyperintense on both T1 and T2 weighted images. So what do we have with us? We have a large mass which is occupying the left hemithorax, right? And on MRI, we can see that there are few areas which are hyperintense on both T1 and T2. And on post-contrast sequence, we can see that heterogeneous enhancement is seen within the tumor, but where the bleed had occurred, that part is not enhancing and it's showing the necrosis. So again, the imaging is very non-specific, but these are some of the tumors that you have to know, because when you make a differential, that you know that this kind of tumor can also occur. So this is actually the gross specimen of the tumor, and you can see that it is a fleshy mass, And this brown area is actually the part which was hemorrhagic and which appeared hemorrhagic on the MRI. And if hemorrhage is there, then obviously you should think about infantile fibrosarcoma. As the name suggests, it is infantile, so mostly in less than 1 year, it is a differential. And if the child is more than 1 year, this should be lower down in your differential list. Coming to the fetal lung interstitial tumor, it is also called FLIT. And as you can see, we are now actually dealing with the fetal lung interstitial